call the Compass MS Care Series. Tonight's program, we are supported by EMD Serono, Bristol Myers Squibb, and Genentech. And our exhibitors for tonight are Optum, Sanofi Genzyme, TG Therapeutics, Novartis, Bristol Myers, and EMD Serono. And again, because we're the only MS organization providing live in-person events, Pharmaceutical is very much behind what we're doing and to be able to be there for all of you as well. Patricia Pagnotta has been speaking for MS Views and News for a number of years. She was part of our medical advisory board when we first started the organization. This was going back in 2009. All right, and she's been leading the charge for people with multiple sclerosis and bettering their health for a multiple number of years. She works out of the Maitland MS Center, I believe, the Greater Orlando MS Center, I believe in Maitland, Florida. And for those that are local, I'm sure you're very lucky to have Patricia Pagnotta as a nurse practitioner in this area. All right, thank you very much, and let's welcome Tricia Pagnotta.
Thank you, Stuart. Okay, so I am going to put this up here, take off my glasses, and take off my mask. So I am sure that you all can hear me. I most of the time can get my voice to the back of the room even without a microphone. So I want to thank MS Views and News for having me, and I want to thank all of the sponsors for this program tonight. I really appreciate so much the opportunity to be here, but also the opportunity to share with the persons who I don't see right now. But this is good information, and I have put less on these slides to be able to, A, cover them as thoroughly as needed, but B, to allow you to be able to answer questions. So as always, Stuart gives me a ton of things to talk about, and I couldn't figure out how to title this. So new, continue, access, and wellness. So first and foremost is what are we talking about with MS? And so the first thing that we all who specialize and treat MS recognizes that there is a window of opportunity to make a difference in a person's life. And so we have an urgency to get you on a disease-modifying therapy. We know through natural history studies, and that's people who, before we had disease-modifying therapy, that's what we call natural history. What happened to individuals prior to disease-modifying therapy? What happened to people? Then we know through the reiteration of the technology, the ability to better diagnose persons. Initially, the poser criteria for diagnosing persons with MS was that you had to have a relapse, you had to have a second relapse, and after that, we could start to diagnose a person. Now, today, we can diagnose persons in the right condition. Now, so don't take that everybody gets diagnosed with one MRI and one symptom. But for some people, it is that simple, one MRI and one symptom. Back then, it didn't matter how good the MRI was, how many lesions you had. If you only had one attack, that was not what we were able to treat back then. So we know what delayed treatment does for individuals. We know the earlier we treat persons, the better off people are. We also know that within that 5 years, first 5 years of a person's disease course, the better controlled we keep them, the better off they will be in the long run. And I remind persons, what I'm doing for you today is not about today. It's about where you're going to be down the road, okay? So the window of opportunity really is getting on a disease-modifying therapy as soon as possible. So I have heard persons tell me about the horror story of, well, it wasn't one MRI and one symptom. It was, several symptoms. I was to the point where, like Jeff said, he was relieved to find out he had MS, because I don't know what his diagnosis process was, but some people tell me that they've been through so much they feel like they're crazy. By the time that I tell them they have MS, they thought for sure that there was something else wrong with them and were relieved to have a diagnosis. So whatever it takes to get your diagnosis, get there. When a diagnosis is confirmed, then you need to get on therapy. So this here is a list. And many of you know that there's many disease-modifying therapies. And so what I've given you here is a little timeline. I've given you the name that we call these drugs as their medical name and then their trade name. So you see that the very first disease-modifying therapy came out in 1993. And there was actually a lottery to get that therapy then. Not everyone could. And so then disease-modifying therapies started proliferating, but it wasn't really until 2000s that we really moved on to having several disease-modifying therapies. And we are still moving forward with disease-modifying therapies. On this slide here are 23 disease-modifying therapies. 23 disease-modifying therapies that are FDA approved. That's wow. That, I don't know. I see people in the audience here. I don't know who is online. But that is an awesome number in a very short period of time. I wanted to break it down just a little bit further into, I gave you 23 different drugs. When I look at a drug to talk to persons about a drug, what I start talking about is, because I can't go through 23 drugs. It's impossible. If I did, the person would be underneath the table before I got to drug number 6. So I start just talking about, what do these drugs do? What is their mechanism of action? That's what we call it. How does the drug work? We have to start talking there, because it's very important that we have a common understanding about what this drug is going to do to you. Okay? So let me remind you, multiple sclerosis is a chronic neurodegenerative disease that is immune mediated. So we are looking at altering your immune system in some way so that your immune system does not attack your central nervous system. So our very first drugs were what we call immunomodulatory therapies. They did not suppress your immune system. They tried to modify how your immune system worked in a way to keep your immune system from attacking you. So they made your immune system less inflammatory, made the markers so that your immune system did not get kicked up as much and required so much more to be able to attack you. And you see that there are several drugs, and I put up the trade names for these drugs so it would be easier for you to identify this versus that whole list, okay? Then there is a drug that generally suppresses your immune system. What do we call that? Some people refer to that as chemotherapy. And general immune suppression is just what it says. We are going to knock out your immune system, not specific cells. And Nivantrone was a drug that did that. It worked very well at the time when we didn't have other therapies. It has fallen dramatically out of favor because of the risk profile. But what that did was dramatically wipe out your immune system. And in fact, there was only a certain dose that you could get of that. Then we have drugs or a drug that blocks your immune system. It does not suppress your immune system, but it blocks your immune system. So your immune system cannot get into the compartment that it needs to cause MS. Doesn't cure MS, but for your immune system to cause you to have MS attacks, increased disability, or MRI lesions, the immune system has to be inside of your central nervous system. So if you can try to keep it, make the blood-brain barrier thicker so that the immune system in your periphery, in your blood system, vascular system, cannot get into your central nervous system, then you are, in essence, reducing the immune system, but in one compartment. And so then there is immune sequestration type of medication. So these are drugs that don't destroy any cells, but they hold them captive. So they hold them in a compartment so that you have less of those immune cells, and so therefore less immune cells, less chance for potentially causing attack on your central nervous system. Then we have drugs now that deplete your immune system. And so we have drugs that go in, target specifically, knock out part of your immune system, and either that immune system will come back and needs to keep being knocked down, or depending upon how we do the depletion, there may be a chance for a long-term without a disease-modifying therapy. So those are the basic mechanisms of action. So when I talk to an individual, I have to talk about that. And in this day and age, part of what I was challenged to tell you about is MS and COVID. And so that's one of the things that I have a very serious conversation with people. We need to, talk about what these drugs do, what's going on, what risk are you willing to take, and what monitoring is required. And so we need to have conversations about that. So it helps if we can at least kind of put things in boxes as to where things might be and move from there. So when we look at considerations for disease-modifying therapy, again, it's extremely important that we early on get control of your disease, that we reduce clinical and subclinical attacks, that we delay progression, we delay or prevent disability. Now, how do we do that? You know, I tell a individual, okay, I'm going to prescribe this drug for you. I need to do monitoring at this point, and I would like you to come back and see me, at this point. Now, over the years that I've been practicing, I've gone from handwriting to quasi dictating to typing, and now I have what we call an electronic medical record. And that electronic medical record has the ability for an individual to get in and, in essence, send me an email. There's an old-fashioned way. You could call the office and get through any office's phone system. But the goal is, and I try to set persons up for, well, I need to see you here. But if something happens in between, don't be waiting until the appointment to say, hey, well, 2 weeks ago I had X, Y, or Z happen to me. These disease modifying considerations are things that you, as well as I, need to own. We need to be a partnership together. We need to know about physical impairments, something that might be attacking you. But one of the things that people sometimes don't recognize is that physical impairments are just one piece of MS. And we recognize now sometimes physical impairment is the least of what can happen to an individual. Now, I'm not minimizing those of persons who are having difficulty walking, who are using wheelchairs, who are using walkers. But if all we look at is physical ability, we are leaving out so much. And so that's important that when you talk to us about your symptoms, don't just talk to us about the things that your family members can see. Talk to us about other things. Know that this disease is highly variable and unpredictable. Somebody in the audience talked about being able to exercise in heated water. That's the only kind of water I would want to be in, but I don't exercise in water, but anyhow. But I know several persons, and I know way back when we used to try to diagnose people, we stuck them in warm baths and then pulled them out to see, well, could they move as well as they did before we put them in that hot water? So, but it's highly individual. I have some individuals who tell me they cannot tolerate this little bit of cold snap we're having here in Florida. And for those of you online, it is in the 50s here. But for other people, this is, oh my gosh, they love this weather. And I'm talking about, I got a turtleneck on and my office is so cold. And they're like, oh, this is great. This is absolutely fabulous. It's very individualistic. So it's important that you think about that you don't think about, well, my neighbor had this and then she went on this and this is what happened to them. Talk about yourself. Adherence is extremely important. If you don't adhere to ed therapy, then we don't know how efficacious it's going to be, because we look at clinical studies to tell us how efficacious a drug is, but that's in persons who adhere. So it's important, again, go back to that mechanism of action. Talk to your healthcare provider about what it is that you have to do to be on that drug, and then can you adhere to that? And so early identifying, again, what you can do and doing it is extremely critical. So every disease-modifying therapy, just so that you know, every disease-modifying therapy that is out there has been proven to have some benefit. Okay, so there is not a disease-modifying therapy that does not work. They're all good. They all work. Are they all going to work for Nancy? Maybe not. Are they all going to work for Jane? Maybe not. Maybe John, who we think that would never work for John, it works great for. So the key is there were 23 drugs there. All of them work. It's important that you get on a drug and you adhere to a drug, so start somewhere. Start somewhere. We can go from there if we need to. Now I want to tell you about the big dilemma, because I just told you start somewhere. It's very important that you be on a disease-modifying therapy. You will never, ever hear me say, I don't support disease-modifying therapies. If you do, I have lost my mind. Please call somebody and get me help immediately. But the debate now in our community is really escalation versus induction. What does that mean? Well, if we go back to natural history of multiple sclerosis and the evolution of those 23 drugs I gave you, and you look at the timeline and you look at the mechanism of action, and we started talking about each one of these therapies, that is escalation therapy, because our earliest drugs out now When we brought them out in 1993, when we brought beta-seron out, you would not have heard us say that this is such a safe drug. But over years, we have proven that this is a safe drug. It's very expectable. We know about what it's going to do, and it has a certain level of efficacy. And the drugs that have come out after have had a bit higher efficacy. Now, not all of these drugs have head-to-head trials. The injectable medications, early injectable medications, all have head-to-head trials. We don't have head-to-head trials in every single drug, but we, as a whole, think of certain drugs being better than or more efficacious than another. Remember, everyone's individualistic, and maybe John is going to do fine on the lowest efficacy drug we have the rest of his life. Maybe he's not. So, but the thought about escalation therapy is we're starting with less efficacious, most safe. We wait for an attack or disability or MRI event to occur, and then we kind of move up the line. And so moving up the line is changing the mechanism of action. Because if we stay on the same mechanism of action, that's like, okay, I'm going to walk this way, and then I'm going to come over here and walk this way. I'm still going forward, but it's just, am I walking on this corner or this corner? So we want to change the mechanism of action. So that's moving up a bit, changing the mechanism of action. And in theory, through escalation, we're talking about them potentially more risk, drugs that have not been out as long. And then we do the same thing. We wait for the next event to happen, and then we move up. So that's what escalation is. And so that's what we have historically had, because that's how the drugs have proved themselves out to be. Now we look at induction therapy because we have drugs that are much, much more efficacious as a whole. Now, we have not done a head-to-head trial against some of the higher efficacy drugs and some of the platform therapies. But nobody would do that trial. But we know that some drugs are higher efficacy. So I'm talking to you with my medical cap on, not a scientific cap, okay? But what we do know about these higher efficacy therapies, they have more potential to cause you a side effect, maybe. They have more monitoring that's required. And they may have more long-term things for us to consider. And so what we think about is giving a person a really strong therapy, see how they do. And hopefully, if it was a perfect world, that really, really strong therapy, if they went on a really, really strong therapy enough, they might stay on that for a very long time. And we say, okay, life is good. You've been fine. Let's try giving you something that's a little safer, doesn't require quite as much monitoring, and potentially go to a drug that is safer. So that is the paradigm of where we are right now as prescribers. And I ask you as consumers to think about that. Where do you want to be? And have that discussion with your healthcare provider. Because I tell persons, I am not afraid of not one of the disease-modifying therapies that is available or who are coming out. None of them scare me as much as MS. I don't have MS. I don't live with anybody that has MS. No one in my family has ever had MS. But my work family, people I see every day, people I love and care about, have MS. And I can only imagine what it's like to live a day in some people I treat's shoes. And so, yes, things are worse than MS, but I don't wish MS on anyone, but I'm happy to say that we have many things. So I need you to participate in that and talk about what risk are you willing to take? Where do you want to be? Because it's all about you. It's all about living your best life with our assistance. I have now talked about all I'm going to talk about is old. I want to introduce you to a new class of disease-modifying therapies. These drugs are not FDA approved. They're in clinical trials. They're called BTKI, Bruton's tyrosine kinase inhibitors, okay? And they are an evolution of BTK drugs. So these drugs are drugs that specifically go in and modulate the B cells in your periphery. So when we're talking about your periphery, I'm talking about your vascular system. When I draw blood and little blood goes in a tube, that's the blood that's running around through your body and is going through all the tissues and whatnot. That's your periphery. That's the blood that potentially can get across that barrier between your periphery and your brain and your spinal cord and get in there. So what these BTKI drugs do in the periphery is they work on B cells. They signal B cells to either live, die, get more, get less, change to be a little work a little different, migrate in, migrate out, and whether or not they mature and become adult B cells. So it's all about how we modulate the B cells. Maybe some of you have not heard about the fact that the cells that we know that are most important in multiple sclerosis are your T and B cells. The B cells, as I like to explain to persons, are the commanders in your army. So your immune system is your army of attack to keep you from having all kinds of things happen to you, to regulate whatnot. And so the B cells are the commanders, but B cells are part of what we call an adaptive immune system, where your body has learned. These B cells have learned over time about things that they shouldn't do. They should attack this faster. Oh, well, this is a normal type of cell. I should leave that one alone. So the cells grow, mature, and learn to move around based off of our needs. And so these BTKIs will go in and modulate to some degree, deplete, or stop B cells from being able to mature, to know, to have memory, okay? So that's very important. That's what's happening out in the periphery. And so that's where all of the disease-modifying therapies we have right now work. Every one of those 23 drugs that we have right now do something to your immune system in the periphery. We believe that some of those drugs may, by working in the periphery, may affect what happens in the central nervous system, but they don't necessarily get into the central nervous system. Now, these BTKIs are a little bit different. They actually can get into the central nervous system, and they will work on both the innate, which is what you're born with, the immune system that you're born with that hasn't learned anything, that just thinks about, okay, well, when this cell starts dying, I need to go up and clean up the debris and take it away. We call that microglia. They go around and macrophages, and so they're like the trash collectors of natural cells dying wherever they are. But in your central nervous system, when you have cells dying, it's okay to have them come around and sweep up a little bit, but you don't want them sweeping into where there's good cells. But you also want the trash to go out, because if you don't take the trash out, that can build up and cause issues. So these new drugs, we are very excited about them, because not only do they work in the periphery, but they can get into the central nervous system, and they can start helping with that trash collection to help modulate, help get that trash collection under control, so that potentially we might be able to see less inflammation inside the brain and more chance for neuroregeneration. Because as Jeff talked to you about plasticity occurs because you have cells in your brain and your spinal cord that are still alive and can be activated. But if we don't keep those cells alive and allow them to be available for activation, you might get a little bit better, but you don't really create another network. The beautiful thing about our central nervous system is that there is so much redundancy that it takes an awful lot before we start having the lack of ability to have plasticity. But we know that happens, again, if we don't treat people aggressively early, we run into losing plasticity. So that's the beauty of this class of medications. And so this next slide, this is the best news I have for you. If you look at these drugs up here, these will all be what their scientific names are. They'll come out with really pretty, better, easier to spell, easier to pronounce names if they get FDA approved. All of these, remember, are in clinical studies. None of these can you go and get unless you have certain cancers. Some of these drugs, this mechanism of action, not these drugs, but this mechanism of action, again, we're pulling from oncology to learn this. But these drugs are in clinical trials for multiple sclerosis. Sanofi, EMD, Biogen, Roche, Novartis. 5 leading pharmaceutical companies have a vested interest in bringing these drugs to market. I don't know what that says to you all, but that says to me, oh my goodness, 5 different think tanks. Because these companies have some of the smartest researchers in the world. 5 different think tanks are working on an evolution of something to be potentially new. Will they be better than some of the high efficacy therapies or some of the platform therapies? We don't know. We really don't know, but the way that they work is very intriguing to us, is very captivating in that we can potentially get something into the central nervous system to help us out. Will these drugs be used as monotherapy, meaning this is the only drug you get, or this will be in combination with another therapy? We don't know yet. The good thing is, if you have MS, the categories I wrote over here, RRMS. Well, it's really RMS, but I left it up there as RRMS because that's how most people identify relapsing forms of multiple sclerosis. ASPMS, active secondary progressive MS. Then there's secondary progressive. How many people in this room know that there's a drug that might become available for a person who is getting worse but not having attacks? We're using these in clinical studies with all forms, active primary progressive and primary progressive. So if you're sitting in my audience here, I encourage you to look me up and to look up my center, but also go to clinicaltrials.gov. I don't know if there's one in Daytona. I don't think there is a large MS center here in Daytona, but I don't know. But all of these clinical trials are occurring in my center and several of them around the country. So if you are interested in considering something like this, this is new and exciting, and so you could potentially get on board. But this is something that is, you should keep your ears out for what's going to happen, because some of these studies are well into their way of that we've been doing them for a while. So we're hopeful that this is not going to be a 5 more year process to get drugs out to market. So again, keep your ears and eyes open for these things. Now, Jeff, I did not even know what Jeff was going to talk about tonight. I had no clue what Jeff was going to say. He didn't know what I was going to say. So Jeff brought up Epstein-Barr virus. And I have to echo his sentiments that I can't tell you, as long as I've been practicing, I've heard about Epstein-Barr. I've told persons that I talk to, well, what causes MS? Well, we know that there's some genetic component, we know that there's some environmental component, and we know that there are some viral things, some things that cause your immune system to become active, and we don't know what it is. But we have always known that Epstein-Barr has a high affinity to persons that have MS. It's never been that everyone that has MS has Epstein-Barr. And persons on the side of, let's say I was a cheerleader for getting Epstein-Barr, which is a type of herpes virus. It's a herpes virus. If I was a cheerleader for it, you need to get that and get it done with so you are good. Well, I don't have to cheer too hard, because most people do get Epstein-Barr. Even people that don't think they've ever had it, we test them and they've had it. So it is what we call a very prevalent or ubiquitous disease. And so it's a common virus that we see. So in Harvard, they did a study looking at 10 million. Can you imagine this? 10 million young adults. Where do you get 10 million young adults? The military. So when you go into the military, there's mandatory blood tests that they do. Okay? And so everybody that goes into the military gets blood work drawn. And so this study group was able to get blood samples that had been done for something totally different. But they were able to find 10 million young adults and look at their virus load and had they ever had Epstein-Barr, and then go on and monitor those individuals through a measure that's called neurofilament light, NFL. It is a measure that we have now in clinical trials. Hopefully, this also will come to market soon. But it's a way of looking at how much activity or potential damage is occurring in your central nervous system. And so there was a 32-fold increased risk of MS after exposure to Epstein-Barr, and we know this from the elevation of that neurofilament light chain. Okay? So that's extremely important. 32% chance increased risk of developing MS after an Epstein-Barr infection. The other thing is they looked at those 10 million individuals and they followed them and found the ones that went on to have MS, and they got 801 persons that developed MS. And of that 801 person, only one had not had a prior exposure, did not have the antibody for Epstein-Barr. So what does that mean? That is the most compelling. That just came out in January. January, I think the publication was the 13th or the 22nd this year. So that's why everybody has been reflaming or refanning this Epstein-Barr conversation. But that study was being leaked out long before it came to publication, because we already have a study looking at the development of a vaccine for Epstein-Barr. We also already have a study looking at developing from a person's blood, extracting that Epstein-Barr and trying to create a therapy with that to see if we can use that in treating MS. So the implications for this are phenomenal. If we could vaccinate everyone as an infant for Epstein-Barr, we would reduce the rate of MS dramatically. So I tell people in my lifetime, I want to see a cure for MS. Well, if I can, out of a population of 801, drop the incidence down to 1, whoo, a good thing I do a few other things other than MS, but anyhow, but that would dramatically reduce our population. If we could then just think about, maybe we're not going to give people vaccines early, but we'll give it to them a little bit later in life, and we still reduce the incidence of Epstein-Barr significantly, the amount of conversion to MS is dramatically lower. And this is the tip of the iceberg. Again, we know that there are several genes that are more highly associated with MS. We know that viruses, and Epstein-Barr happens to be the one that we know the most. But the more we find out about things like this, the closer that we get to a cure or more efficacious therapies. If not at least a mechanism for getting a therapy into a person's immune system, because some of this Epstein-Barr work may be used to have that drug be able to penetrate the immune system in a different way. So again, this is groundbreaking, phenomenal work. So those of you who are living with MS, keep on keeping on. And to that end, what is keep on keeping on? What keep on keeping on is resilience. And so resilience is the capability of a strained body to recover its size, shape after deformation caused by some compressive stress. And so that's the technical term for that. So it just means that your ability to recover, your ability to keep on keeping on. But the thought of keep on keeping on in the best way possible is what I encourage persons to think about. So what about MS threatens a person's resilience? Because I have met several people who have told me that MS was the best thing that ever happened to them. And I've met several people that have said, this is the worst thing. And I can't, but were those two individuals, say, were they like that prior to MS? Because, some people see life as full of possibilities. Some people see life as, it's a bunch of mind traps. I just need to try to, everything's out to get me, and I just need to, I've gotten through today, and I have to worry about tomorrow, So we have to think about that. But we do know that MS itself, the neurodegeneration that is part of MS, that is characterized by relapses and disability, does make changes in the chemical being of your central nervous system and makes it difficult for resilience. So if you have resilience, pat yourself, any type of resilience, pat yourself on the back that you are fighting against what is happening in your central nervous system that might not be completely under what you think is your physical or mental ability to change. We often know that neuropsychological complications directly come from the inflammation and the demyelination. So the thought was, well, are persons depressed because they have MS? Or is it the depression? Is it the MS that's causing the depression? Well, early on, we thought everybody was depressed because they had MS, because why wouldn't you be depressed if you have MS? I look at people come in and tell me, I'm thinking, oh man, that must really be bad. Maybe I would be depressed if that, but it's not just that. We know that these chemical changes that are occurring cause these phenomena, the chemical component that causes depression, anxiety, and some other things. We also know, because this is a chronic neurodegenerative disease, that threatens a person's autonomy, independence, dignity, and future plans. I don't know about any of you as you were listening to Jeff. When I don't listen to myself talk very often, other than, I guess what I'm hearing here. But when I listen to a person talk who has MS, versus me talking who's standing up here, and I'm just giving you my experience. I've never walked a day in your shoes. But when I hear Jeff talk about the fact that, I don't know what tomorrow's going to be like. None of us know what tomorrow's going to be like. I don't know that I'm not going to go out there and somebody's not going to run me off on the road and something terrible happened to me. But the probability of that versus, if I had MS, the probability of potentially having a relapse, or always worrying about that. So we do know that itself makes it difficult for persons to have resilience. So if you have resilience, again, you're fighting an uphill battle, and give yourselves many kudos for that. It's up that works the best. So what is the risk of low resilience? So when we look at the physical features of having low resilience, we know that your sympathetic nervous system responds to stress by increasing your heart rate, constricting blood vessels, causing your blood pressure then to go up, decreasing your digestion, and increasing the release of glucocorticoids. So therefore you have more sugar in your body, your blood pressure is going up, your blood vessels are being damaged, your heart rate is going higher, you're developing heart failure potentially. So we know these are physical things that are happening to you. And we know that if persons have low resistance over long periods of time, that will interrupt your immune system. It will cause many medical problems: hypertension, diabetes, osteoporosis, cholesterol problems. So we know that there are physical symptoms that occur from low resilience. When we talk about the neuropsychological features that happen with low resistance, well, the most common: anxiety, depression, cognitive impairment. People who cannot focus and concentrate. It's not the cognitive impairment that we think of that comes from lesions. Irritability and anger. Those are the most common. Very less common, infrequent would be disinhibition. Persons who just go out there and all of a sudden become totally different individuals and have no concept of doing the right type of thing. Psychosis, people that are having hallucinations or terrible dreams. Apathy, people who apathy means you just really don't care. Don't care about anything, or other type of behavior disturbances that less frequently occurs with low resilience. So if you're having any of these physical or neuropsychological features, think about where are you on that scale of resistance. So what can you do to build resistance? Well, stay hopeful. I hope that the first part, when I talked about the disease-modifying therapies, that there's 23 options. The fact that every single one of those drugs work. The fact that if one doesn't work, we can move to another. The fact that we are still very actively engaged in clinical research trials looking at continued what we know of the immune system and moving it from different disease states to this disease state, to trying to treat better, to try to find neuroregeneration, to try and find a cure for MS. Stay hopeful about that. And so we know that there have been several studies that have been linked to hope and improving quality of life. So that's extremely important. And higher self-efficacy. So being determined, I'm not doing this because I have to do this. I have to get up and I have to do this. I'm doing this because I am a leader of my ship. I'm responsible for where my ship goes, and I'm going to steer it. I'm going to become knowledgeable. I'm going to work. So we know that that is helpful. And stay involved in your care. So that's a no-brainer. So what can you do? You can do all these different things. So drugs are not to you, they're for you. Do the things that Jeff talked about. Sleep, hydrate, eat well. Identify things that are not predictable and know that you can't control those and move on. So don't harp on those things. Be optimistic. Feel strong. Get comfortable at handling uncomfortable situations. Know that you can handle certain things. Use humor. Find people to be around that will help you. And look for close and dependable relationships. Look at things as challenges. Okay, how am I going to get through this, and how can I do this different? And so look at things as a way to move forward and build on. So barriers to access of care in MS. And so there is a real recent article in the fall of 2021 in the International Journal of MS talking about access of care issues. And the two biggest concepts were lack of information, but inside that lack of information, in the two things were the persons with MS and the healthcare providers. Okay, so the persons with MS Do they really know what MS is? Do they know about the 23 different disease-modifying therapies? Do they know the things that they can do? Do they know what power they have? Do they? And how are they educating themselves? How are they assessing themselves? How are they communicating that? And then in rural areas like this, I don't know what it's like, what your neurologist, your neurology nurse practitioner, or your PA is like out here. So, how much does your healthcare provider know? And so making sure that you and your healthcare provider work as a team, and maybe you need to periodically be seen by in an MS center. Look for support, because lack of support is a huge barrier to healthcare. Lack of social support, not having someone to be with you. Negative interactions with a healthcare provider, that ranks right up there as number 3. That is so sad, and I apologize, but I can't make that better. But if you had a bad experience with the healthcare provider, that's not the whole world. Find yourself a different healthcare provider. If you can't find one, call your insurance company and find another. Personal beliefs. That is a big barrier to healthcare. Do you believe that one of those 23 drugs might work for you? Perceived time. Some people think, well, I don't have time to go on that drug because she wants to see me or have blood work done, blah, 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 and I need to do that. I don't have time for that. I don't want to do that. Lack of finances. That's very real. So look for resources, way that you can help that. Make sure that you are talking to your healthcare provider. Make sure that you're talking to the drug companies. Make sure you're calling MS Views and News. They have a social worker. The MS Society has a social worker. MS Foundation. All these people are advocates for you, so make sure that you find the ways. Physical barriers. I know some persons have told me they haven't had a GYN checkup in, they can't remember when, because they don't know of a GYN where they can get up on the table. And so things like that, look for ways to get around that, and finding resources through the advocacy associations will be helpful. So plan ahead. It's very important to plan ahead. Maintain your insurance. If you have a change in your insurance, you need to tell your healthcare provider immediately. You need to tell whatever drugs that you're on immediately. You need to go to GoodRx or whatever. Keep communication open with your healthcare provider, and use the community resource organizations to be helpful to you. So, wellness amongst COVID. One of the things I want to tell you is that as a whole, persons with MS don't do worse than the general population. So Stuart admitted to us, or told us, thank you, Stuart, for sharing that with us, that he had COVID. Stuart's risk of doing worse was not because he had MS. So we know that MS has not been an independent risk factor. Now, that does not mean I'm encouraging any of y'all to go out and get COVID. And does not mean I'm encouraging any of you all not to go get vaccinated. I'm just saying that MS itself, and potentially the disease-modifying therapy you're on, will not affect your ability to do well with COVID. We do know that the B-cell depleting drugs do have a more difficult time in persons getting a more adequate immunity from the vaccines. So we know that persons who are on B-cell drugs, they don't get the same level, but we don't know that it's not sufficient enough. But in the COVID-MS registry of persons with MS who have gotten COVID, it looks like the B-cell depleting therapies are a little bit higher risk. But when we take out all of that, the comorbidities, really as an overall, I believe it's making them look worse than they really are. Here it is. So wellness with COVID. Treat your illness. What can be worse than having COVID and having untreated MS? Oh my goodness, then you might have to go to the hospital, because some people tell me every time they get a relapse, they go to the hospital. Well, at the height of COVID, if you went to the hospital, they turned you away and said, that's not, you're not dying. Get out of our emergency room. So you were no better in going to the hospital, but then unfortunately you got yourself involved where you may have run into COVID. So treat your illness. Stay on your disease-modifying therapy. Make sure that you're doing the preventative health activities that you need to. Eating right, exercising, taking care of your other risk factors for disease, treating your high blood pressure, treating your diabetes, all of those things. Reduce stress, meditate, stay socially active. Now, how can you stay socially active in a pandemic where they're telling you to stay away from people? Well, MS Views and News has managed to do it. We saw Jeff, and I don't know where Jeff is. I think maybe he's down there in the Miami area or something. He wasn't in this room, but we saw Jeff. I've seen family members of mine that live 1,400 miles away from me on a regular basis. So there are ways, they're not the same ways, but there are ways to stay socially active. So I encourage persons to do that, because we know that feeds hope. That feeds your willingness, your resilience, and your ability to survive. So those are the things. And like the rest of all of us, when you go to Publix or wherever you shop, if they didn't have toilet paper last time and they have it now, get one, maybe get two. I don't know. But if you can do things that help you out, look how shopping online has come to fruition. Some places don't even charge you extra to bring your groceries to your car. All you have to do is pull up and they put the groceries in your car. Isn't that wonderful? So there are things that you can do to help yourself. So don't not take care of yourself. And that is my last slide.
Awesome. Thank you. Great. Thank you very much for that. I know people in the audience have questions, and we also have questions from people online. In fact, there's so many questions of the people online that I don't know how we're going to do them all. All right, so maybe some of them will have left by the time I get to them. Anyway, does anybody in the audience have questions? Because I want to see who does, and then I'm going to start with what's online, and then I'm going to come back to the audience, okay? So if you do have a question, please raise your hand, all right, and then we'll get to you as well.
Can I walk around with this?
Nope.
No. Oh.
Nope, you're grounded.
I'm grounded.
You are grounded.
I thought maybe we could do two.
You are like a bit in isolation up there, okay? Okay, and by the way, if you want to get more than one toilet paper, go for it. It's there.
But napkins aren't.
The napkins are.
No,
Either is the cream cheese.
Well, and,
right?
and coconut flakes, unsugared coconut flakes.
All right, let me ask a question here. So this is, I'm not mentioning any names. A person is writing, if no meds have worked for depression and anxiety, are you familiar with ECT?
I am familiar with that. That's electric currents that they give. I know it. I'm not a psychiatrist, so I don't give it, but I know it has been helpful to persons with major depression, so I would check a psychiatrist out and see if that would be helpful. Okay.
Another person is writing, how are the immune selective depleting drugs such as Lemtrada or Okravis different from the general immunosuppression drug, as you mentioned, the Novantrone, that did not do well? Seems like they all block a good part of the immune system. Just wanting to understand this better.
So Novantrone had no selectivity. It went in and depleted not only T, B cells, monocytes, neutrophils. It went in and wiped out the immune system. And the problem with Novantrone was not the problem of an immune deficiency with persons getting infections or cancers or whatnot. It was the cardiac toxicity that Novantrone had. So if persons got through the fact that they might be higher risk for developing a cancer or getting an infection, they still had to deal with the fact that it was toxic to your heart. That's why you could only get so much, because if you got more than that, you were going to have heart failure. So it affected your whole immune system plus cells that your immune system affect. Whereas the Lemtradas, the Okravis, the Mavenclad, Kesimpta do not. They selectively go towards T, B, or TMB cells.
Okay, great. Next, we have a question back here.
Okay, I think you just answered my question in that last statement, but I was going to ask you, what are some of the B cell depleting drugs?
Okay, so Lemtrada depletes B cells, T cells. So Lemtrada is a B cell depleting therapy because it gets rid of T cells, you might have long-term efficacy with that. With Mavenclad, it gets rid of B cells and some T cells, not as many, but it is a B cell depleting therapy. But because it's hitting both marks, you have some long-term potential for not needing to retreat. With Kesimpta and Okravis, you are just depleting B cells. So B cells, as they grow back, you need to re-knock them out. So you're just getting rid of a population. So when that population starts growing back, you need to hit them again. In the instance of Kesimpta, you're dosing yourself all the time, so you're never allowing for potential repopulation until you stop.
So I have a quicker question than we tried last time. So are there studies being done with patients that have two autoimmune disorders, of meaning I have MS and I have lupus, and I'm taking Aubagio for my MS, and I'm taking Plaquenil, the old 1940s drug, for malaria, and they're doing good. I'm better than I've been in years, but of any studies that are being done for both to see how the long-term effects of taking these drugs are?
God bless you, and I'm going to pray for you. But the question she asked is very difficult. When we are designing clinical studies, there is criteria to be able to get in. And if we are studying how a drug does for multiple sclerosis, we don't want too many other variables there because it might be a problem. So as a rule, I would tell you, if you have lupus and MS, you're less likely to get into a clinical trial, but you're doing well, so keep doing what you're doing.
Okay, anybody else have a question? Great.
I have MS and have had it for several years now, but I'm not on any medication at all. Should I be on a medication? I've had reactions to other medications that I've been on, but should I be on a medication of some sort? I do have a lot of fatigue.
I am not your healthcare provider, so I don't know your particular situation. But as a general statement, there are 23 drugs. I doubt you've been on all 23. And what I say to persons when they tell me, I think I want to go off of a therapy, I don't want to do that, I'm doing well, I recovered, I'm doing good now, blah, 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 all the things that they tell me. Well, that's fabulous. And I hope it stays that way. But you have a chronic degenerative disease that you are playing Russian roulette with. And are you willing to take the risk that you're going to lose something else? And if you have a disease course like secondary progressive that's not active and you're just slowly declining, right now we don't have, quote, a drug for that, but we have them in clinical studies. So again, I don't know your particular situation, but I would just give that some consideration.
Thank you for that. So I have a person online that's asking, what can you tell us about which is the best monoclonal antibody to use if contracting COVID as being an MS patient? Which monoclonal antibody are they giving, like other than Regeneron?
So we're talking about a treatment for COVID-19.
Yes.
Okay. I do not want to comment on that because I know that there are several monoclonal antibodies out there, and they've pulled some of them off because they found that they're not effective for the Omicron. But I don't treat COVID. So I would refer any of my patients to an infectious disease doctor or to a hospitalist that treats COVID. I'm not a COVID specialist, so sorry.
Okay. Another question online is, where in the United States can I go for stem cell treatments?
There, you can go on to, there is the Coalition for MS has that, the Consortium of MS has it, but you can go on to National Clinical Trials.gov. They are all requiring that individuals have active disease with active MS plaques. So again, you need to look at the study site and find out what the criteria would be. And if you're talking about outside of clinical studies, just Google it.
Okay, thank you. Another person, well, that's a question that I have to answer. They want to know when MS Views and News is going to get to Roanoke, Virginia. Hopefully by the end of this year. That's all I can say. All right, next one. Okravis is a B-cell depleter like BTKI. Is the biggest difference between the two drugs, or what is the biggest difference between the two drugs? That the BTKI will actually rid the brain body of the neurotoxins, the garbage that builds up, and cause an inflammation storm?
So the biggest, again, it depends upon which one of those BTKIs. I was telling you about what the capability of the B cell modulation could be, but the difference in that beyond just how they'll modulate the B cells will be that, yes, there is entry into the central nervous system to help with getting rid of the inflammation that's occurring so that you can have regeneration. And so Okravis does not have any way to get into the central nervous system. It only works in the peripheral nervous system. It only gets rid of B cells in the periphery. It doesn't do anything to B cells in the central nervous system or the microglia, which are the trash compartments. So in your central nervous system, you also have B cells. So you have B cells up there that are leading the charge for your T cell gets a little inflamed and the B cell saying, okay, go get this myelin, run after this one. So you do have leaders up there. You have TMB cells that are living in your central nervous system.
My neurologist, when I found out I had MS, sent me for a cognitive function test so we could get a baseline. So 8 years in advance, I have moderate cognitive function loss. So at what point do people generally need to find out about their cognitive function for a baseline or decline so that they know how much the MS is affecting and effecting them?
That's a very good question. And so having a baseline always gives us something to measure. Many individuals that I want to go have neuropsychological testing won't do a baseline until they are experiencing some cognitive difficulties because they don't want to spend the money, spend the time. They don't want to go through that. They're working, they're doing fine, they think they're fine. They don't want to, I don't care what I'm like right now. I'm doing great. Maybe I had a learning disability. I don't know. I'm doing fine. I am not affected at all. So the majority of people turn me down for that. When I start getting cognitive testing is when an assessment of mine or they start, or their family members, support people start talking about cognitive decline. And then we start going into getting that to feel what are the components of that cognitive decline. How much is from MS? How much might be from pain? How much might be from medications? How much might be from depression, anxiety? And then it gives us a treatment strategy for that. And then also that is used in individuals who may not be as physically impaired, but are having difficulties in their current work environment and need that support, because if they go before Social Security and they look like me, there are some people that have MS that look like me. That's why I always tell you I don't have MS, because there are people that look okay. And you might even say to that person, wow, you got MS? Well, the Social Security Administration is definitely saying, no, you can be out there working.
All right, so a person is writing, I wasn't diagnosed until I was already into secondary progressive. I have opted not to use DMTs. I use medications for symptom management. What are your thoughts?
If the person does not have active secondary progressive, we do not have a disease-modifying therapy FDA approved for non-active secondary progressive.
Exactly. Okay, next. You mentioned hope, but what effects do you see with gratitude and blessings?
Well, I think that gratitude and blessings are a offspring of hope. I would say that they have the same capability. Have they been studied? No, but we do know that persons that have a higher belief, irregardless of what religion that is or what that belief is, people that have a higher belief do better. So that has been studied not just in MS, but in other chronic disease states.
Okay, thank you. Next one, shouldn't cognitive testing in order to get a baseline of functioning be covered somehow and be considered a vital biomarker?
Amen. And so the advocacy organizations and the Academy of Neurology, we're all fighting for that. But when you find a way to help us with that, I appreciate it.
Okay, guess what? I get to say thank you. So thank you. I couldn't shake Jeff's hand, but I wanted to come up here and say thank you to you. And there we go. Thank you. And I thank the audience for being here today. All right. And you just showed that this is possible. Okay. And it's something that we've been trying to do in various portions of the United States, and we will continue to do. MS Views and News at this point in time is the only patient advocacy organization in the United States doing live programs, live in-person programs, all right? And not only that, but we are still doing 10 to 11 programs per month, primarily virtually, okay? So you can go onto our website, and you can always see the center column of the website. And this is for anybody online and anybody here in attendance. You go to the website, you look at the center column of the website, and it shows you all the events that are happening each month, okay? So if you get on at the beginning of the month, or if you look at our newsletters, it's listing everything at the beginning of the month. Our newsletter comes out, and it shows you everything that is happening during the course of that month. So we do hope that you learn from this, and we do hope that you could turn others on to what we're doing, all right? And continue to learn. Continue to learn and continue to learn how to fight this disease, okay? So get out there and do it. And you all have a great night. Thank you.